Our patient. Meet Bruce. Bruce is a 57-year-old Caucasian male who is married with 2 kids. His height is 152 centimetres and he currently weighs in at 92 kilograms, resulting in him having a BMI of 39.8. This score indicates Bruce falls into the obese category, which increases his risk of developing heart disease, as well as other health conditions. Bruce has been working as a construction worker for over 25 years, which requires a large demand in walking and standing on hard surfaces. He has recently attempted a new fitness plan to reduce his weight, but due to severe pain in his feet and lower leg, he has struggled to complete his exercises. Bruce has a family history of obesity, as both of his parents were categorised as obese. He has also suffered from extreme hypertension as well as type 2 diabetes. Bruce has no relevant pediatric history as he has never visited a podiatrist before. After experiencing chronic pain in his feet and lower leg, Bruce decided to finally visit his local podiatrist. The following notes were taken. The subjective information that our patient detailed included the complaint of pain on the plantar aspect of both of his feet, as well as experiencing a severe pain after exercises and long periods of standing. The pain is usually the worst within the few steps after awakening. The objective information that we gathered included our patient's legs and feet, which appeared swollen due to his obesity, and both the hair and nails surrounding the area appeared normal. Pain was experienced with the palpation of each heel, and it was identified through the use of an X-ray that our patient's fascia was swollen. Upon assessment, it was diagnosed as plantar fasciitis due to the signs and symptoms that our patient presented with. Our plan included a shoe/sock assessment and recommendation, in which we evaluate the footwear our patient currently uses and assess if this is a causative factor for his condition. Debridement and pain relief medication was also involved. Our evaluation included identifying goals for future consultations. These included things such as reducing pain in the morning, reducing inflammation around the plantar fascia, as well as seeing an improved range of motion of the ankle.
When identifying the relevant diagnosis and problems for Bruce, we can list multiple different conditions. Plantar fasciitis, characterized by weakening, edema, and/or irritation of the plantar aponeurosis. Peripheral neuropathy, damage to nerves impairing sensation, movement, gland or organ function, or other aspects of health dependent on the type of nerve affected. Retrocalcaneal bursitis, which usually shows symptoms of a fluid-like sac over the heel where the Achilles tendon attaches to the calcaneus. Achilles tendinopathy, a general term for tendinitis or tendinosis affecting the Achilles tendon. Now, as we look at the relevant anatomy involved in the scenario, we can identify plantar fasciitis is the major source of pain for the individual. Clinically, this presents as a thickened aponeurosis due to the edema extracted from the X-ray. This originates proximally from the medial tubercle of the calcaneus and inserts distally at the metatarsal. The aponeurosis is made up of 3 components: the medial, central, and lateral areas, where the central component is most commonly associated with plantar fasciitis. The small plantar nerves located in the surrounding fascia serve in registering and mediating the pain. In addition to the aponeurosis on the surface of each foot is a fat pad, which is found superficial to the plantar fascia. This fat pad predominantly consists of multiple adipose layers. The function of this fat pad is to maintain protection of the lower limb whilst absorbing a large portion of the force throughout the lower limb. Subsequently for Bruce, excessive weight and energy will be put on these structures within his feet.
There are multiple causative factors for plantar fasciitis, some of which include obesity, age, trauma, footwear, foot mechanics such as high arches and flat feet, prolonged weight bearing, occupations that keep you on your feet, and ankle dorsiflexion. In relation to Bruce's scenario, there are numerous factors that could be contributing to his condition. Firstly, Bruce's obesity can place a large amount of pressure on his plantar fascia. This, combined with his demanding job, could be considered a causative factor. Secondly, Bruce's age may lead to a loss of the normal cushioning provided by the plantar fat pad. As age is closely related to fat pad atrophy, his old age may be a causative factor for the chronic pain he is experiencing. Footwear and foot mechanics can also be a major causative factor for Bruce's condition.
Obesity has shown to strongly alter foot function and structure through various mechanisms that include modifications to biomechanics due to flat feet, alterations to plantar fat pad, decreased muscle strength, and abnormal gait parameters. Obesity individuals with foot pain have extensive progressions of fat mass tailored with increased body mass index that has been shown to increase mechanical loading of the lower limb during walk and gait, which contributes to the development of plantar fasciitis. Increased weight generates an enhanced loading for the tendons that creates stress on these structures in conjunction with decreased stiffness and greater thickness of the plantar fascia that can reveal changes in the mechanical properties. Increased BMI may be a risk factor for chronic plantar heel pain, which is most commonly caused by plantar fasciitis due to high vertical forces produced under the heel, creating internal stress within the heel, leading to damage of soft tissue structures and developing symptoms. Research conducted has shown that a significant association between BMI and flat foot reported that overweight and obese individuals were more than twice as likely to have flat feet. As the heel contact is insufficient during pronation of the foot, this induces dorsiflexion of the toes, creating increased tension of the plantar fascia. As a result, a flat foot can't perform adequate tasks under excessive weight loading, and pathologic change induced by stress is repeatedly applied on the plantar fascia. If a pronated structure is untreated, thickness of the plantar fascia increases over time as flat feet show unbalanced weight loading from decreased muscle strength and range of motion in dorsiflexion.
As highlighted previously, there are a variety of factors which have been shown to cause plantar fasciitis. In line with the case study presented, it was determined that obesity is a contributing factor in the development of plantar fasciitis. The studies found that there is a link between BMI and chronic plantar heel pain, as the following research containing evidence-based reviews, systematic reviews, and meta-analyses. The main findings from each of the texts include, as per Cole 2005, plantar fasciitis is more likely to occur in obese individuals and contains a variety of multifaceted treatment options including stretching, tapes, and corticosteroids. The systematic review conducted by Irving in 2006 found that chronic plantar heel pain is a common soft tissue injury, and there were 16 articles identified a strong link between BMI and CPHP and plantar fasciitis. McMillan 2005 indicated that ultrasonography is widely considered the best detection method, and there is a large fluid retention and subcalcaneal spurs that are the reason for pain. In the Butterworth Systemic Review of 2012, 25 papers were found supporting the claim that there was a strong association between BMI and heel pain in a non-athletic population. And then finally, as per the Riddle research article, ankle dorsiflexion was considered the main cause of heel pain, and when in conjunction with a BMI of 30 plus and prolonged standing, is heightened symptoms of heel pain.
Plantar fasciitis is a reversible condition and can be treated very successfully. About 90% of the people with plantar fasciitis improve significantly within 2 months of initial treatment. If plantar fasciitis continues after a few months of conservative treatment, the podiatrist may choose to inject the heel with steroidal anti-inflammatory medications. Cortisone injections have been shown to have short-term benefits, but they can restrict your progress to medium to long-term. Due to poor foot biomechanics being the primary cause of plantar fasciitis, it is vital to thoroughly assess and correct the foot and leg biomechanics to prevent future plantar fasciitis episodes or the development of or progression of a heel spur. Podiatrists are highly skilled in foot control assessment and its dynamic biomechanical correction. Depending upon the specific clinical assessment, a podiatrist may provide a manual therapy techniques such as joint mobilizations to loosen stiff joints, soft tissue massage release, muscle flexibility or stretches, foot taping, foot and lower limb strengthening exercises, and occasional night splints. Activation of foot stabilization exercises are excellent long-term solution to prevent and control plantar fasciitis that may be prescribed by the podiatrist. Researchers have concluded there are essentially 8 stages that need to be covered to effectively rehabilitate plantar fasciitis and prevent recurrence. These are early injury protection, pain relief, and anti-inflammatory modalities, regain full range of motion, restore foot arc, muscle control, Restore normal calf and leg muscle control. Restore normal foot biomechanics. Improve your running and landing technique. Return to sport or work. And footwear analysis. Ultimately, biomechanical correction is the aim. Foot intrinsic muscle strengthening and calf stretches are almost always required.